Hi, everybody. It is 7 p.m. in Paris, 6 p.m. in London, noon in New York, and it is my great pleasure to welcome you all to this live webinar by the International Academy for Clinical Hematology. I'm Mohamed Moti from the Sorbonne University and Saint-Antoine Hospital in Paris, in France, and our guest speaker, top expert today, is Professor Anne Quinquenel, who is the head of the Department of Hematology at the University Hospital of Reims in France. So you may know Reims in France for all the lovely champagne. This is the country of champagne in France. But actually, we have also at the University Hospital of France, Professor Quinquenel, who is really an international expert in the field of chronic lymphocytic leukemia. And this is really a disease where we've seen an incredible amount of advances, including actually oral therapies. But still, despite these advances, the management of high-risk CLL remains a matter of concern. And probably we still need a lot to do in this field. Obviously, all the BTK inhibitors are really proving to be amazingly effective, but still, I'm sure Professor Quinquenel will share with you her thoughts. And please do not hesitate to post your questions, your comments, your suggestions. And obviously, at the end of the webinar, you can claim your CME point because this webinar has been accredited by EBA. So without any further delay, I would now give the floor to Professor Quinquenel. Anne, bonsoir. The floor is yours.
Thank you very much, Mohamed, for this kind of introduction. So thank you also for inviting me to deliver this talk. And I will talk today about management of high-risk CLL. And as usual, these are my disclosures. So what I was thinking when I started to prepare this webinar is to try to define what is clearly high-risk CLL at the current time. And what we will try to do is to look at what is high-risk CLL in frontline treatment. So which patients do we clearly identify as high-risk CLL? And when you think about high-risk CLL, you also have to think about patients in the relapse setting who have been exposed to both BTKI and to venetoclax, and who are really a matter of concern. So this will be the second part of my talk. So to try to begin with the definition of high-risk CLL, we have to remind us that it was quite clear at the era of ICT, and we had well-defined predictive factors at the era of immunochemotherapy. And we had something that was really clear in first line, which was fludarabine refractoriness patients, and these patients were the ones who were considered as high risk, along with patients with 17p deletions, and patients who were relapsing less than 2 years after fludarabine after FCR were high-risk patients. And we were discussing, for the ones who are young enough, an indication of allograft transplantation. So with the advent of targeted therapies, things have dramatically changed in the good way, hopefully. And there was a need to redefine the concept of high-risk CLL. Even in 2018, both the ERIC and the EBMT tried to make a work together to try to define the concept of high-risk CLL. And if TP53 patients were still high-risk CLL, there was a lot of other concerns. And the indications of allograft really were diminished, and there are almost only a few allografts in France for high-risk CLL, maybe less than 30 per year. So that's what is interesting, is that we have to redefine patients which are called high-risk CLL, and we have to know if we have to treat them differently, and that's what I'm going to try to talk today. So I will start with first-line treatment, and what I will do is first try to remind you the main studies in first line, and then we'll have to focus on sub-analysis to try to know if we have predictive factors from these studies. So at the current time in first-line treatment, we have three main options, which is BTK inhibitors until progression, fixed duration with obinutuzumab and venetoclax, and maybe the newest one is a fixed duration with ibrutinib and venetoclax. So if we start with BTK inhibitors, of course, the main one, the older one is ibrutinib. And what is interesting with ibrutinib is that we now have a really long follow-up, which is interesting when we talk about CLL. And the RESONATE trial, which was the first phase 3 trial, which compared in first line in patients over than 60 years old, ibrutinib to chlorambucil. So the comparative arm is not really interesting, but what is interesting is the data, because we have 8 years of follow-up now. And if we look at the 7-year PFS, it's almost 60%, which means that after 6 years of ibrutinib, 60% of patients have not relapsed, which was really the best result we've ever had at this time with first-line CLL treatment. One of the main points with ibrutinib was that it was not the most specific BTK inhibitors, and there were side effects which were called off-target with inhibition of other kinases of the same family or even EGFR. And so second generations of BTK inhibitors, which are also convalent, were developed. And we have data with this, what we call the second generation BTK inhibitors. So the first of the one was acalabrutinib. So acalabrutinib is now fully available in France and in a lot of other countries. And the main trial who led to the acalabrutinib approval is the ELEVATE-TN trial. So we're starting to have quite a long follow-up, but we'll still have to wait a bit to have PFS, and I think that it will be updated in ASH in a few days. So for the ELEVATE trial, this compared acalabrutinib to acalabrutinib and obinutuzumab to what was treatment of reference for ICT for unfit patients, which is obinutuzumab and chlorambucil. So for these patients, this trial was designed for patients who were considered as unfit, who were more than 65 years or had CIRS greater than 7, or who had creatinine clearance less than 70. So what we have about the 5-year PFS, it's about 85% in the acalabrutinib plus obinutuzumab arm and 72% in the acalabrutinib arm. So this trial was not powered to try to show a difference between acalabrutinib and acalabrutinib plus obinutuzumab, and I think that all the experts don't agree to see if we really have to add obinutuzumab to acalabrutinib. And maybe we'll have to discuss about that if we want. And the last available is zanubrutinib, which is also a covalent BTK inhibitors. And as the newest one, will have the shorter follow-up. And zanubrutinib was compared in first line to bendamustine and rituximab in a trial called Sequoia, for which we now have 43.7 months of follow-up. And what we'll have to know about the Sequoia trial is that patients with 17p deletions were in a separate arm, and they all received zanubrutinib, and that's quite interesting because we can have data on ibrutinib in first line with 17p patients, and I will show you that later. But if we focus to the main cohort, we can say that with zanubrutinib, the estimated 42 months PFS is 82%. So that's really good results. And of course, we'll have the longer follow-up with ibrutinib, but all BTK inhibitors show really, really good results in first line. So another way to have prolonged PFS in CLL patients in first line is to choose a fixed duration treatment with obinutuzumab and venetoclax. And the two main trials which demonstrated the efficacy of these trials are both the CLL14 trials, which was mainly dealing with less fit patients, and the CLL13 trials, which has less follow-up, but which was designed for younger patients. So if we try to see the data of the CLL14 trials, this was a trial for so-called unfit patients, but as often in clinical trials in CLL, the patients which are considered as unfit are less unfit than the one we have in our consultation. And this trial compared obinutuzumab and venetoclax for 1 year to obinutuzumab and chlorambucil, and the patients were quite the same as in the ELEVATE trials. And this trial has been presented many and many times. And what is interesting that when it was last presented at last EA, we have the median PFS. And with this trial, the median PFS is now 76 months. So you can say that with 1 year of treatment, you have a PFS of 76 months, which is also really, really interesting. Focusing to the younger patients, so another trial from the German CLL group was recently presented and published in the New England Journal of Medicine by Barbara Eckert and her colleagues. And these trials had the objective was to compare standard ICT for fit patients, which was FCR for patients younger than 65 and BR for patients who were older than 65. And in this trial, this was compared with 3 regimens containing venetoclax. The first one was rituximab and venetoclax, and the second one was obinutuzumab and venetoclax, and the third one was what was so-called the GIVE regimen with obinutuzumab, venetoclax, and ibrutinib. And this trial was presented in 2 parts because the main objectives were twice. The first one was PFS, and the second one was UMRD with a threshold of 10-4 at the end of the induction phase, which means at M15. So these results were presented, and what we can see from this data is that the arms containing obinutuzumab and venetoclax are having better results in terms of UMRD and in terms of PFS than immunochemotherapy and then venetoclax and rituximab. So one of them, what we can learn from this trial is that in first line in CLL, obinutuzumab is the best anti-CD20, but we can't draw any conclusion on the interest of adding ibrutinib to have a sort of three therapy in CLL. But this trial clearly shows that obinutuzumab plus venetoclax is better than FCR and is also better than rituximab and venetoclax. So first we have BTK inhibitors until progression. Secondly, obinutuzumab and venetoclax. And the newest one is a combination of 2 main treatments in CLL in first line is ibrutinib and venetoclax for a combination of 12 months. So in this regimen, patients receive 3 months of ibrutinib, and then they have 12 months of both ibrutinib and venetoclax, and the treatment is stopped after 1 year of treatment of both therapies. And the phase 3, which interested to this trial, is the GLOW trial, which was also designed for patients who were unfit. And of course, as in the CLN14 trial and in the ELEVATE trial, the arm of comparison was also obinutuzumab and chlorambucil. And what we can show from this data is that the 4-year PFS is 75% about, which is also really interesting with 15 months of treatment. I will also present you a few data on what's so-called the Captivate FIRX duration, because it was a phase 2 designed for younger patients, because the median age in this trial was 60 years old, so not the same population than in the GLOW trial. And this was a phase 2, and this is a fixed duration, the same design, 15 months of treatment, 3 months of ibrutinib, 12 months of ibrutinib plus venetoclax. And what was seen is that we had less side effects in younger patients, but the 4-year PFS was also the same, which is about 80%. So we have these 3 regimens, and the next question will be how to choose which treatment for which patients. And if we focus to our talk, which patients have to be considered as high-risk patients. At the time of immunochemotherapy, the best predictive factors were, of course, TP53 abnormalities, but also mutated IgG status and also complex karyotypes. So I'm just going to show you which data we have in this trial with this subpopulation, but we have to be cautious that it's only subdata, it's only subpopulation analysis, so it gives us information, but we have also to take it with caution. So if we look about TP53 alterations in first-line CLL and in ibrutinib, the results were really great, and that's one of the main reasons. For example, in France, ibrutinib was really fast approved and reimbursed in patients with TP53 deletions and 17p deletions, even in first line, because there was really an unmet need, and even with only very few data from clinical trials. So at that time, we have really great results with ibrutinib in patients with TP53 alterations. And I try to summarize a few data from phase 2 studies or from a pooled analysis of studies. But what we can see from all this data is that the PFS of 5 years is almost 70%, maybe a bit lower than what we see in the RESONATE trial, but really good results, and far until now the best results in patients with TP53 alterations in CLL in first line. So which data do we have with second-line BTK inhibitors? We also have, I'm sorry for the slide because it's a bit difficult to read, but we also have very good results with both acalabrutinib, as shown in this slide. The patients with TP53 mutations or 17p deletions are in plain, and the patients without mutations are in dotted. So it's too early to conclude now, and maybe it will be a little less good in patients with TP53 abnormalities. But at that moment, we can't see anything about acalabrutinib. And if we focused on the arm C of the Sequoia trial, which I explained you a bit before, you can see that the PFS and the OS of this patient is really interesting. So that's why we still consider that TP53 abnormalities are high-risk CLL in first line, but it's better than ever with BTK inhibitors. And why do we think that it is the best treatment? Because if you look at the impact of TP53 alterations in patients receiving obinutuzumab and venetoclax, mainly in the CLL 13 trials designed for older patients, we can see that the 17p deletions is, when we look at multivariate comparison, the only factor which is predictive for shorter PFS along with bulky disease. So there is really less good results in patients with 17p deletions or TP53 mutations in the CLL 13 trials. No patients with such abnormalities were included in the CLL 14 trials because we did not want anymore to expose patients with TP53 abnormalities to chemoimmunotherapy. And finally, we can say that 17p deletion and maybe TP53 mutation is really a predictive factor for shorter PFS in patients treated with obinutuzumab plus venetoclax. And if we finally look to ibrutinib and venetoclax, we have a few data from the Captivate trial that I just presented you a bit earlier, and no patients with TP53 alteration were included in the GLOW trial, so I don't have any data on that. But if we look at the Captivate trial, we have a small number of patients who had TP53 abnormalities, and they may do a bit worse, but at that time it's not possible to have really statistical comparison, and that's really too early to conclude. But a lot of experts on CLL just think that when you have patients with TP53 abnormalities in the first line, it's interesting to have a prolonged treatment and not fixed duration at that time. So this point is for TP53 abnormalities. And if we now focus to the IgHV status, which was really a predictive factor when we were talking about ICT, what we can see quite clearly is that there is no impact of IgHV status when you treat patients with ibrutinib, and we really have the same results with acalabrutinib. So we can quite clearly say that the IgHV status is not predictive of shorter PFS in patients treated with BTK inhibitors. The things are quite different when we talk about the combination of obinutuzumab and venetoclax. And if we look to both the CLL14 and the CLL13 trials, in multivariate analysis, patients with unmutated IgHV have a shorter PFS than patients with mutated IgHV. That does not mean that we must not do this treatment for patients with unmutated IgHV, because the results are anyway good and the patients are treated only for 1 year, but we have to be aware that the results are much better with patients with mutated IgHV status. So we can say that the mutational IgHV status is clearly predictive for PFS in patients receiving obinutuzumab and venetoclax. And finally, and that's really interesting for our combination with ibrutinib and venetoclax, this was presented by Carsten Niemann at last ASH, and it was really published in The Lancet just a few weeks ago. It seems that we have quite differences, but it's too early to conclude between mutated and unmutated IgHV patients receiving the combination of ibrutinib and venetoclax. And at the beginning, when the results were presented for the first time, there was no difference in terms of PFS, and what was interesting is shown in the right panel. So when we were focusing on minimal residual disease with a threshold of -10-4 or 10-5, what was seen at the beginning is that the MRD rates were much higher at the end of treatment in patients with unmutated IgHV than in patients with mutated IgHV. So at the beginning, we were thinking that maybe we had to perform IV for patients with unmutated IgHV and GV for patients with mutated IgHV, but things are a bit more complicated, because with longer follow-up, we can now see that, of course, there were lower rates of UMRD patients in the patients with mutated IgHV, but as you can see on the right, this UMRD is clearly maintained. On the contrary, even if we have higher rates of UMRD in patients with unmutated IgHV, most of them lose their UMRD and the PFS seems to be shorter. So it's a bit too short to conclude, but maybe it will be a predictive factor. And that's also a good lesson to try to see that we don't have to try to interpret the results too early, because if you just focus on one point of minimal residual disease in this particular point, it does not seem to represent what will happen for longer time. So that's quite interesting. So it's a bit difficult to clearly have an answer, but maybe it may be predictive for inferior PFS for patients with unmutated IgHV when receiving ibrutinib plus venetoclax. So if I try to focus now on the last predictive factor, which was clear when we were talking about chemoimmunotherapy, it's the complex karyotype. There's some little debate in the CLL community to see if complex karyotype is greater than 3 or greater than 5 abnormalities, but in most of the trials you have both results. So if we look firstly on this retrospective study from the Ohio State, well, it was both first line and relapsed refractory patients, but there is clearly a difference in terms of results, and especially for patients who are with greater than 5 abnormalities. If we look to a phase 2 study from the Italian patients, which were using ibrutinib and rituximab in unfit patients, you also see that you have shorter PFS, what you see on the right, if you have patients with more than 3 abnormalities. So it seems that complex karyotype is predictive, for patients with ibrutinib in first line. If you look at obinutuzumab and venetoclax, things are quite clear because it was both studied in the CLL14 and in the CLL13. And in the CLL13, in multivariate analysis, you really have shorter PFS in patients which have complex karyotype, whatever the treatment, even in patients treated with combination of obinutuzumab and venetoclax. But in this particular case, it is only true for patients with more than 5 abnormalities. And I think I don't have any slide for ibrutinib and venetoclax and complete karyotypes because I don't think that we really have clear data on that. So I'm sorry for having shown so many results, but I will try to summarize in this slide. So first is that we have to remember that no predictive factor was formally identified in dedicated prospective trials, and what we have are subpopulation analysis and also real life data, which are really interesting data to try to put all the things together. And I have tried in this table to summarize. So what is in red is a predictive factor which were clearly demonstrated in multivariate analysis. In orange, you have putative predictive factor demonstrated in univariate analysis or real life data. And when you have the red cross, is that the factor is clearly not predictive. For example, the ADHV status is not predictive for inferior PFS in patients which are which are treated with ibrutinib. On the contrary, the HV status is clearly predictive when you use obinutuzumab and venetoclax, and it may be predictive in patients treated with ibrutinib and venetoclax, but we need a bit longer follow-up. TP53 alterations are clearly predictive for shorter PFS when receiving obinutuzumab and venetoclax. It might be the same thing for ibrutinib and venetoclax. With long follow-up in trials, patients with TP53 abnormalities may do a bit worse when receiving ibrutinib, but the results are clearly very good. And if we look at complex karyotypes, this might be predictive in all combinations, especially on ibrutinib and venetoclax, but also maybe on BTKIs. So this leads me to our French guidelines that I'm going to present you now, which were updated this year. So first of all, we have to think about a clinical trial when we think about treating a patient. And then the first thing that is interesting is to look at TP53 alterations. And if you have TP53 alterations, 17p deletion or TP53 mutations, we all think that BTKI are the best treatment for these patients. So if we look at other guidelines, for example, in the German guidelines, the other thing that is present with TP53 alterations is complex karyotype, and these patients really have to be treated with BTK inhibitors. And this can be also discussed for patients with complex karyotype. We have to know that in first line, most patients do have patients which have complex karyotype. Most of them have also TP53 alteration, but we have a few patients that have complex karyotypes without TP53 alteration, and it can be discussed to also put them in the right part of the diagram. For patients who don't have this, I think that the second thing that is really important is the mutational EGHV status. And I tried to show you that for patients with mutated EGHV status, the association of obinutuzumab and venetoclax is really doing well and is our treatment of choice. I think that another option will be ibrutinib and venetoclax. but we'll have to wait for a bit longer follow-up to know if it's also a treatment of reference for these patients. And we see that we can see that we let the FCR combination, and that was a long discussion between us when we tried to summarize our guidelines again recently. But I think there is almost no reason for doing FCR in patients anymore at this time. So for patients with unmutated AGHV status, the choice may be a bit more difficult because it's almost impossible to know what would do better between BTKIs and venetoclax and obinutuzumab or ibrutinib plus venetoclax. And I think, of course, in terms of PFS, BTK in a continuous treatment may be associated to the longer follow-up, but it's treatment for more than 5 years, and in the other hand, you have treatment for 1 year, which also made really good results. So I think that's something that has to be discussed with the patients on both his preference and also on his medical history. So it's quite unclear to, it's not obvious to make clear recommendations. So if we summarize, for patients with TP53 alteration, we'd rather have BTK inhibitors until progressions. In patients with mutated AGHV status, our treatment of choice is obinutuzumab and venetoclax. And for patients with unmutated AGHV status, of course, we can discuss fixed duration treatments or BTK inhibitors, depending of the choice of the patients or a lot of other parameters. So if we now look to relapsed and refractory CLL, I'm not going to focus on so many trials, but something we all have to be aware of is that we'll have patients which will be exposed to all our oral therapies and which will be refractory to these treatments. And what we'll really have to distinguish is what we call double exposed patients who received both BTKIs and venetoclax, and patients who are considered as double refractory, which means that they are refractory to both of the treatments. And another concern will be when we do fixed duration treatment, will we be able to restart treatment with the same molecules? So this is something I picked from the American Journal of Hematology. It was a proposal from hematologists to consider what is a double refractory patient. So of course, it's patients who were treated, were refractory to one line of treatment and who progress on the second line are refractory. But what is a matter of debate is if we do perform a first line treatment, for example, with obinutuzumab and venetoclax, how long has to last the response so that you can consider that patients are not refractory and that you can start the same treatment again. And that's, we don't still have the answer. We know from the CLL14 trials that when we retreat patients with venetoclax after venetoclax first line, it can work in some patients. But what we have to discuss and what we have to define is for which patient it will be better to change and for which patient it will be better to switch for another therapy. And these authors in this particular paper just proposed 24 months, which means that patients who are treated with, for example, BTK and venetoclax or venetoclax and anti-CD20 who progressed early after the end of treatment should be considered as refractory to this treatment, but this still has to be defined a bit more precisely. So this leads me again to our French guidelines in relapse and refractory treatment. And of course, we have to wait for a symptomatic relapse in the absence of available clinical trials. And what you have to perform when a relapse occurs is to try systematically to search for TP53 abnormalities if they were not present at the previous lines. And what's also important is if you want to use again BTKI, for example, after a first course of BTKI, I think that's important to search for mutation of resistance, for example, mutations in BTK or in PLC gamma 2. The other thing which is important in relapse is to always think of the possibility of a Richter syndrome. And if you think that your patient may have a Richter syndrome, you'll have to perform a PET scan and a biopsy. And then we can divide the patients into four categories. First of all is the patients who were neither exposed to BTKi or VEN, and we still have these patients. They are the one who relapsed after a first line of chemoimmunotherapy. And then you have the choice between venetoclax and rituximab in the Murano trial regiment, but you can also use BTKIs, and in these particular cases, maybe choose the second line in inhibitor, because in head-to-head comparisons, they seems to be less toxic than ibrutinib. For patients who were exposed to BTKI but not exposed to VEN, it means the patient relapsing on ibrutinib or having stopped ibrutinib for other reasons. It's quite important to distinguish patients who are refractory to BTKIs to patients who are intolerant, because of course if you are refractory you have to change, but for patients who are intolerant to BTKIs, you can either go on for venetoclax and rituximab or to switch to another BTKI. But if you want to switch to another BTKI, you really have to focus on which side effect was responsible for the withdrawal of the first BTKI. And if you had a severe adverse events such as serious bleeding or a really important cardiac effect, I think it would be better to change. Finally, for patients exposed to VEN and not exposed to BTKi, it may be patients who are treated, for example, with obinutuzumab and venetoclax in first line. So if they are refractory to VEN, of course, you have to change. But if they are, if you had a scheduled discontinuation after 1 year of treatment, for example, well, you may think about restarting venetoclax and ibrutinib, and maybe with rituximab, and that's what I was talking about a bit earlier. We have to determine the duration of response that we have to fix to think that restarted the same treatment will be a good thing rather than changing treatment. And finally, one which is maybe now our greatest challenge in CLL, along with Richter syndrome, is patients who are double exposed to both BTKIs and venetoclax. And what is important is, as I told you a bit previously, you can be exposed and not refractory. And of course, if you are not refractory to one of the two treatments, you have to go on with the one who are not refractory to. And for patients who are double refractory to both BTKI and venetoclax, or who are refractory to one treatment and have resistant mutations, which makes us think that we are not going to have a good response to the second one, we'll have to think about something new. So we can think about, of course, clinical trials when available. We can think about pirtobrutinib, which is the non-covalent BTKIs, which may have good results in these patients. It's not available again in France, but we'll hope that soon we'll be able to use this treatment. This may be a good indication for idelalisib plus rituximab. Also, the response may not be very long, but it can be thought about a bridge. And of course, for these patients, if we are able to make them respond to a further line of treatments, and if they are young enough and if they have a good donor, we have since now to think about allogeneic transplantation. And for this patient, which still represent now an unmet need, I will just show you a few slides before the end of my talk to deal with what is the newest treatment in B-cell malignancy, which are CAR T cells and bispecific antibody. And what is specific for CLL, and I did not have enough time to go on with this subject, is that patients with CLL are really have immunodeficiency, both on B cells with hypogammaglobulinemia and also on T cells. And this immunodeficiency on T cells is really responsible to a lack of efficacy of targeted T cell therapies. And I will try to show you that in the flu slides. So I tried to summarize an overview of data on CAR T cell therapy, and I'm not going to discuss on all trial one by one, but what we can say is that it's clearly disappointing in patients with CLL comparing with all other patients with indolent B malignancies, for example, for follicular lymphoma or even with other B-cell malignancies. And our explanation is really that the T cells are exhausted and they are dysfunctional, and it may lead to shorter efficacy of CAR T cells. And so things were tried to make the T response better, such as using ibrutinib before, but at that time, the result with CAR T cells anti-CD19 are still a bit disappointing. So we also have a few preliminary data with bispecific anti-CD3, anti-CD20, and we have a few data that were really presented at the last IWCLL in October by Arnon Kater. And these are data from the trial called EPCOR CLL1, which was a trial who studies the efficacy and also the, of course, the tolerance, first of all, of epcoritamab in patients who were previously treated in CLL. And as you can see on the criteria, patients need to have received at least 2 lines of prior therapy and were intolerant of refractory to a BTK inhibitor. So, of course, we only have 23 patients. That's a bit short, but we have preliminary data, and the overall response is 62% with only 1/3 of complete response. And if we focus on the duration of response, it's also too difficult too early to raise clear conclusion, but some patients may respond for a while. So I think that these treatments are now in trials, try to be compared in regimens, in association, and maybe we should use them as we try to do in other B malignancy, maybe a bit earlier in the course of the disease. But that's something that is quite encouraging, and I think we'll have to think how we can use bispecific antibodies in the settings of CLL. So to conclude, and I think that will be my last slide, we had major improvement in CLL thanks to the development of targeted therapies, but we still have unmet need. And we have to clearly define high-risk CLL, because high-risk CLL patients may be the one in first line which will shortly become double refractory. And I think that the other concern, even if I didn't have enough time today to focus on that, is that we really need to overcome CLL immune deficiency, because the first cause of death in CLL patients is infections, and try to overcome the CLL immune deficiency may also lead us to have better results with both CAR T cells and bispecific antibodies. And I think I'm over for the moment. I'll be happy to take questions.
Thank you very much, Anne, for really comprehensive and beautiful talk. And you managed in 30 minutes or so to give us really a fantastic overview about this really difficult topic. And we have a lot of questions. I don't think we'll be able to take all of them, but I'll try to summarize some of them, some ideas. First of all, we have one question is, if you have access to all kind of drugs in CLL, what would be your ideal regimen to be closer to cure, for instance? Because one of the comments, several comments we had, is that we never reach a sort of a flat curve when it comes to survival or to PFS.
So I think we quite, at that time, that may not be quite true, because I think we had a flat curve with FCR in some patients with mutated AGHV status, and the one who still defend the idea of making FCR in selected patients is that it's doing really good. We have to wait now to see if we'll have a sort of a flat curve in patients with mutated AGHV with venetoclax and rituximab, but I think we need to have a longer follow-up to be sure that a flat curve is a flat curve. So I really think that obinutuzumab and venetoclax is a good regimen now for patients with mutated IgHV, and we also have to think that a lot of patients with CLL patients are older patients. So even if we are not able to cure them at that time, the median age of CLL is 72 patients. And I think that about more than 20 and 30% of the patients we treat for the first time are older than 80. And when I started with CLL when I was a resident, the first question was, what is the aim of the treatment for the patient? And I think if we have an old patient which is doing well with the first line treatments, we don't necessarily need to cure CLL. We have to be sure that he's not going to have too many infections, that he's not going to have so many side effects. So I'm definitely not sure that I would put everything in the same basket at the beginning, but rather think to the long time of the treatment. And also the trials we would all like to do is trials where we can directly think of the PFS too, which would be the PFS after 2 lines of treatment, which is almost impossible to design as a trial which patient who will respond so long. But I think that at that time I would go really on with prolonged BTKIs with patients with TP53 deletion. I'm not convinced that adding everything at the same time will be better. For patients with mutated IgHV, I will go for obinutuzumab and venetoclax. And for the one who are unmutated for IgHV, I will also go for maybe I will discuss with the patient, but I'm not sure that we have in hand something that we'll put together to be able to cure CLL. Maybe with bispecific if we use them at the beginning, but we also have to think that we have old patients and they have to live, but they also have to live well. So we don't have to take so many risks for these patients.
Excellent. Thank you very much. We have a few questions about the role of MRD negativity in these high-risk patients, but also whether we can use the MRD to go for fixed duration treatment. This is one of the questions, for instance, Dr. Cuervo.
So I think that's a good question. So we can clearly say that we don't have to perform MRD with BTKI in treatment. And the question is, can MRD be used to decide the duration of treatment? And that's a great question, because some of the trials, such as ERADIC in France, the duration I plus V, or for the FLAIR trial in the UK, the duration of the I plus V depends on the time in which you reach MRD negativity. But what we have learned from, I think, the GLOW trial, and that's really interesting, I tried to focus on that a bit earlier, is that one time point MRD and one early time point of MRD might not be an answer to everything. Because if you think of the GLOW trial, many patients with unmutated IgHV, 60% had unmutated IgHV, had UMRD, and some of them lost it. And at the end, you have shorter PFS in patients with unmutated IgHV. So I think that may be used, but I think we have to wait. Maybe patients who have been treated for long enough to be sure that MRD is a good way to stop treatment. On the other arm, we have data. It was in relapse from the Mireno trial, which was rituximab and venetoclax in relapse. And what was seen clearly in that regimen is that patients who had positive MRD at the end of the treatment, there was no gain of prolonging treatment, because it was clearly shown that it was patients which were at better MRD at the beginning of the treatment and were losing their MRD. So I think it's something we'll have to deal with. One of the great work, I think, is also to make all the lab be able to give us a clear answer about MRD. But I don't think that we have yet the trial which will definitely convince us that only MRD will be used, and the answer may be not the same because of the treatment you use. So I'm sorry not to be clear for that, but I think that it's a true question that is not answered yet.
No, but that's a great answer. It's work in progress, actually. So we have a question about the different BTK inhibitors, and now we have the non-covalent one, which are about to be introduced. And one question is, should we aim to give all patients these days, for instance, based on the results you presented, acalabrutinib instead of ibrutinib, because it has shown better safety profile and superiority? Or is this not a good interpretation of the data?
Well, that's a great question. That's a great question we all have. And what we can say that in relapse, there were two trials, which are the Alpine trial with zanubrutinib and the Elevate RR trial, which directly compared acalabrutinib and ibrutinib and zanubrutinib to ibrutinib. So we have answer in relapse. And in the Elevate RR trials, which was a non-inferiority trials, the results in terms of PFS are the same, but you have less cardiovascular events in the acalabrutinib trials, which I think led most of us to use acalabrutinib rather than ibrutinib, and maybe to extrapolate this in first line. For zanubrutinib, it's not available yet in France, but I think it will soon be reimbursed, so it will be a great question of which one to choose. And the question will be if we choose the second generation rather than the first. And the next question will be between the two second generation, which one do you choose? So in the Sequoia arm, in the Alpine trial, clearly there was a benefit in terms of PFS for the ibrutinib comparing to ibrutinib, but there are endless debates on why the ibrutinib arm did so bad, and there are the results of this trial, so we have these results. To my mind, I don't think that I'm able at that time to choose between acalabrutinib and zanubrutinib, but to be honest, most of my patients in single agents receive second generation BTKIs.
Excellent. So we'll take one last question because it has been asked several times. Dr. Wandru, Dr. Yip, what would be your best treatment for a Richter transformation?
So that's a great question, and I think we have quite interesting data from really short patients which are doing quite well with a regimen of obinutuzumab, a BTKI, and checkpoint inhibitor. But we have, I think, at least two presentations during the last year, which were quite promising, but the response is not really prolonged. So we still have to think about allogeneic stem cell transplantation for these patients if we can bring them in a proper response and if they are young enough to do that. And I also think that in France we had the Blinart trial, and we tried to use blinatumomab in a combination for patients for blinatumomab after R-CHOP for patients who are not in response to R-CHOP. That may have not been the best choice, but in France, a trial will start soon, which is the Glorify trial, which is a phase 2 trial for Richter syndrome, and will make glofitamab R-CHOP to try to have better answers. So I really think that having new treatment by specific antibodies will be nice, and I think we also have to try to think about CAR T cells for these patients. We only have to convince people who make CAR T cells that Richter is a DLBCL, and so we'll have access to CAR T cells.
Thank you very much. This was really an amazing activity. Thank you, Professor Quinquenel. Thank you all for being loyal and for following the ICH activities. Please do not hesitate to claim your CME credits for this webinar. And if you're heading to ASH in San Diego in the next few days, I wish you safe travels. And please don't forget, we'll have a live update about the take-home messages from ASH, including CLL, next Tuesday, actually, at 8 p.m. CET, 7 p.m. Paris time, 11 a.m. San Diego. But in the meantime, please stay safe and keep well. See you soon.